LinkedIn News.
Medicine and healthcare, even though we'd like to think of ourselves as very innovative, we are like
it's an old system.
it is such an old system.
Yeah.
And so it's going to take a while to get out of that traditional way of doing things.
Right.
But I also always bring it down to, look, these are the statistics we have. We're not doing well.
We're not doing it. Yeah, we're not doing great.
No. And our patients deserve better. Like, I think about it as like missed birthdays, missed graduation parties, missed retirement parties. That's how I think about how like racial health inequities in our country impact people.
That's health equity advocate Dr. Uché Blackstock. I'm Leah Smart, and this is Everyday Better. Don't forget to hit that follow button to get new episodes of our show every week. And if you find this conversation, or any others you've heard, valuable, I have a favor to ask. Consider leaving us a review so we can keep bringing you more of the conversations that you love. If you don't know, here's how to leave a review. On Apple Podcasts, go to the Everyday Better page, scroll down to ratings and reviews, and click the number of stars you want to give us. Then, right below that, click Write a Review and add your note to us. On Spotify, go to our page, click the 3 dots next to the settings wheel, and select Rate Show. We so appreciate your feedback, and as always, thank you, thank you, thank you. Hey everyone, from LinkedIn News, I'm Leah Smart, and this is Everyday Better, a personal development podcast where every week I sit down with some of the world's brightest minds and bravest hearts who use science and story to share strategies for how we can flourish individually in relationship to others and to the world around us. As regular listeners of the show will know, I've recently gone through one of the biggest changes a person can experience in their lives, becoming a parent. I am so excited to share that I'm a brand new mom of a beautiful baby girl. And while I'm adjusting to life as a new mom, I'll be taking a little bit of time away from the show so I can be fully present for my new daughter and my family. Don't worry, you'll still hear me in conversation with a fascinating guest every week, like you always do. But you're also going to hear from my amazing producers, Grace and Emily, on a more regular basis. They'll be stepping in to set context for each of the conversations. So with that, let's start the show.
All month here at Everyday Better, we're having conversations inspired by Leah's transition into motherhood and the challenges prospective mothers often face. That's why this week, we're focusing on Black maternal health. For Leah, this was an important topic to cover because in the U.S., Black women are 3 times more likely to die from a pregnancy-related cause than white women. This is a disparity that persists, regardless of education or income level. It affects Black mothers across the country, in both major cities and rural areas. So today, we're joined by Dr. Uché Blackstock, who is here to help us understand what's going on behind these statistics.
Dr. Blackstock is a health equity advocate and the author of Legacy, A Black Physician Reckons with Racism in Medicine. It's a history of how racism has shaped and continues to permeate healthcare in America. It's also a memoir of Uché's journey to becoming a doctor. She and her twin sister, Oni, both went to Harvard Medical School, as did their mother, the late Dr. Dale Gloria Blackstock. And when Uché and Oni graduated in 2005, they became the first ever Black mother-daughter legacies from the program. After medical school, Uché joined the faculty at NYU's School of Medicine. She also worked as an emergency medicine physician at an urgent care in Brooklyn. At the time, this was in 2010, fewer than 2% of doctors in the U.S. were Black women. The majority of the patients Uché saw were Black, though, and so she saw firsthand what racial health disparities look like. She also heard stories from patients who were reluctant to go to the doctor or who had been dismissed by other doctors in the past. All this inspired Uché to start reading about the history of healthcare in America, which was a history she hadn't learned in med school. And what she found had a lot more to do with racism than with biology. So in 2018, Uché founded a nonprofit called Advancing Health Equity, which aims to dismantle racism in the healthcare system. She writes about this mission in her book, Legacy, and she's here with us today to share how we can all play a part.
Okay, so really quick. You might be wondering, what does all this have to do with personal development? It's a fair question, but here's our take. learning about why our society is the way it is, and spending some time thinking about how we can change it for the better is personal development. So with that, here's Dr. Uché Blackstock.
Legacy, it has two meanings. One from the subtitle is more obvious. A Black physician reckons with racism in medicine. And I wanted to help people connect the dots for why in 2024 we see the appalling health statistics that we see, especially among Black Americans, like maternal mortality rate. So I want people to understand the history and kind of the contemporary issues that we're dealing with that could explain why in a country with as many resources as we still have some of the worst outcomes compared to our other high-income peer nations. And then the other piece of legacy is being a second-generation Black woman physician. My mother, who's the original Dr. Blackstock, was my role model and inspiration. And, Black women physicians are less than 3% of all physicians. So I really wanted to be able to give her a voice. And she passed away when I was 19. My twin sister, Oni, and I were 19 years old. And so there's so many people who didn't know about this amazing dynamic woman, as well as her colleagues, that really had a tremendous impact on our community.
When I read that about your mom, I was like, wow, you must be so proud. I hope you are.
Yes, immensely.
Yeah. I mean, to hear that is the start for me of like the shocking number of things that I learned, getting ready for this conversation. Yes. But to hear that you were the first mother-daughter legacy, I was like, how?
I know.
Amazing for you. I'm so happy for you. But also what?
Absolutely. Yeah, at Harvard Med School. And since then, I graduated in 2005. And since then, there's only been one other Black mother-daughter legacy graduate from Harvard Medical School. So, we're still celebrating firsts and seconds when you're like, okay, no. Things should be really much better by this point.
Right. So I actually want to take a step back because when I read that you had so many Black female doctors growing up, it reminded me of my own childhood. I grew up in Oakland in California. My parents were like, and they must have done this on purpose. I mean, my dentist was Black. My doctor, my pediatrician, I didn't know that there was another option. And yet for so many of us, people of color who may want to see people who look like us when we go into vulnerable environments, we don't. Like, what's going on in the larger system that we don't have that access, and why do we need that?
Yeah. So one of the things I wrote about in the book was this report that came out in 1910 called the Flexner Report, which was sponsored by the American Medical Association and Carnegie Foundation. But essentially, it sent this education specialist named Abraham Flexner around to all of the medical schools in the U.S. and Canada to assess them against the gold standards of Western European medical schools and Johns Hopkins here in the U.S. That report led to the closure of actually a good number of medical schools in general, but 5 out of 7 of the historically Black medical schools in 1910. And those were the ones that were educating most of the Black physicians. It's estimated if those 5 medical schools had stayed open, they would have trained between 25,000 and 35,000 Black physicians.
This was 1910. So this was at a time when I'm guessing we wouldn't have been allowed into many of the other schools anyway.
Right. So that's the other point, right? We weren't allowed into predominantly white institutions. So all we had were the historically Black institutions. So Howard and Meharry were the schools that were left over. And to this day, those medical schools, there are actually 2 more that have been open since then. So there are 4 total, but those schools actually still train the most Black physicians.
Wow. Can you talk about why it's so important for there to be more people of color, more Black people that are practicing?
Yes. And so it's not just, anecdotally, people will say, I just feel more, seen, heard, valued when I see a clinician that looks like me. But we actually have data that shows that racial concordance, meaning when the physician or nurse and the patient are the same background, especially for Black patients, that improves health outcomes, that patients are more likely to follow their physician's recommendations. They're more likely, for example, to get their vaccinations. They're more likely actually not to be interrupted while they're speaking to their clinicians. We have data that shows that they're actually people of color and Black people in particular are more likely to be interrupted and spoken over during clinical encounters. There was actually a study that came out 2 years ago in the Journal of American Medical Association that showed that even having one Black primary care physician in a U.S. county improves health outcomes and life expectancy for Black people living in that county.
Why?
So a lot of it, I know. So a lot of
You're
it
like,
has,
how?
I know. I mean, and the fact is that unfortunately, when Black patients interface with the healthcare system, they often are not listened to. So we have a lot of issues around, for example, how pain is treated. Like we know about Serena Williams, who is, the GOAT, who obviously, is a professional athlete, knows her body well, has resources, but even she was not listened to by her healthcare team when she was saying, I'm having symptoms that are similar to when I had a blood clot before. And she had to really advocate for herself and almost died. And so I think a lot of times, I think clinicians, of course, they say, I want to make sure I'm treating all my patients well. I'm giving them the best care possible. But unfortunately, those implicit biases show up in the way that they care for patients.
Where, and I actually I'll come back to this because the socioeconomic part's something you talk about. And I think we know it's a narrative that gets played of like, and actually it trapped me too, someone who's gone to college, who, grew up, middle class and was like, oh, well, maybe that's not going to be my situation because people have said okay, so we know that that's not true.
Right.
And if Serena Williams can't do it, like nobody can, right? But how did all of this start?
Yeah, so a lot of what we see today is deeply rooted in the legacy of slavery. A lot of the medical inventions that we have today, for example, like the vaginal speculum, the speculum that's used when people go to get their gynecologic exams, that was developed on experimenting on enslaved Black women. So there were physicians who were revered within medicine that also were enslavers, but also, performed experiments that were horrific because obviously enslaved people could not give consent. But at the same time, they made these really important discoveries. So there's that, how do we reckon with that? And there have been so many more. So, for example, we know that a lot of medical schools, predominantly white medical schools, did a tremendous amount of experimentation on enslaved people. They were even would go and dig the graves of enslaved people and take the cadavers out and experiment on them. And even today, actually in Texas, they found that one of the universities there were using the bodies of unhoused men who had died, but their families hadn't claimed them. And using them in anatomy labs, but without their family's consent. So
it makes me want to cry.
I know. So it still happens, and that's why it's so important. Like I know that a lot of the health equity advocacy work I do is really just like informing the general public about what's happening, so that we know we're not just in our silos talking about it.
I would never know that unless you said it. I'm like, that I didn't think I'd be brought to tears this quickly. No, it's good. It's like, it's moving in the sense that like, I don't think most of us know that.
No.
So I want to also talk about just the idea of like, of pain in the context of how we've othered people, right? So I think, a lot of our listeners are not necessarily Black women. Like we have listeners of all kinds, right, on this show. And part of the reason I want to do this is because I just think when exposed to things like this and allowing ourselves to actually think about it, we can turn on that empathy skill much better than we tend to when we're all running around the world and going, oh, my life's so busy, my this. And that's okay. We all do that. But I think it's really easy to skirt out on the experiences of others, especially today. So I'm hoping that this gives people a window into not just Black maternal health, but also just the ways in which truth is shifted so that it reflects something sometimes better than what actually happened.
No, absolutely. And I think that it's also really important for people to understand that, like, their lived experiences are very different than other people's. Like even people that they work with, people that are their good friends. I mean,
even siblings.
Even siblings. But we're just, talking about being pregnant, thinking about who's going to be your OBGYN or your midwife. Like for Black women, that's something that we are like thinking ad nauseum about because we know the statistics and we're scared for our lives.
You don't ever want to be in a position where you're like, am I really feeling something wrong, or am I being convinced that, it's like,
Exactly.
I don't want to
No.
ever have to have that.
Absolutely. And I think, the issue that you brought up around pain, again, I think is one that, again, is deeply rooted in slavery, in Jim Crow. Like, there's this idea in medicine that Black bodies are somehow biologically different and we experience pain differently. And that's the whole justification. How can you enslave people without disseminating this message that they're
It's okay
less than
to.
human? It's okay.
Yeah.
And so what's interesting is that even today, a lot of the work I do is actually working on issues around pain and equity, because we know that pain is undertreated in Black patients and other patients of color, even unfortunately in children. Like, there's studies that shown that even in children with appendicitis, Black and Hispanic children are often given less medication. I know.
Wow.
I know. It's absolutely heartbreaking. And I think that if you were to probably talk to those pediatricians, they would say, no.
We don't do that.
No, we
Yeah,
don't. We don't do
course.
that. But unfortunately, it's happening. So the work that I'm actually doing is working with medical schools about discussing these issues during medical school. This is not something I learned about in medical school.
Right.
I didn't know that there was this disparity between how patients' pain is treated. And the issue with that is that often, of course, not treating someone's pain leads to emotional, psychological, physical distress. People, they develop depression, anxiety from pain not being treated. They can't go to work. They can't enjoy life.
I mean, yeah, if you think that when you go to the doctor, they might ignore what you say, you're likely to not go to the doctor.
Right. And I'm so glad that you brought that up, because that's what often happens. We see, especially in Black communities, that there's a high degree of unmet needs. And that's because people don't trust that they're going to be cared for properly. I've taken care of patients who are like, no, I don't want to go to the ER because I'm not going to be treated well. Right. So then what's going to happen with the symptoms that you're having? We could be missing something.
You talk about the fact that you were taught that there are biological differences between Black people and non-Black people, or Black people and white people. Can you talk about that?
Yeah, well, one example I give is the idea around kidney function, that it was based on a myth that Black people had higher muscle mass, but there were and there still are different set of normal values for kidney function for Black patients and non-Black patients. And actually,
There still are.
yeah, only about a third of hospitals have gotten rid of that race correction factor, but there was a race correction factor where there was a different set of normal values. And so the impact of that, though, was that it delayed referral for kidney care for Black patients, and actually it led them not to be placed on the kidney transplant list. So actually last year, National Kidney Foundation went back and had to reprioritize 14,000 Black patients because of these different values that they were used on the kidney transplant list. And so can you imagine those 14,000 people? There were people who actually ended up passing away because they didn't get the care they needed, because essentially these values said, no, your kidney function's normal, when it was actually abnormal.
No. Is that only non-Black patients and Black patients? Are there different values for other?
No, primarily the race correction factors are involving Black patients.
Wow.
And there's actually one for vaginal birth after C-section. In those criteria, you have to put in the race of the patient. In terms of determining who's a good candidate or not. So often the race correction factor will say that a Black patient is not a good candidate for a vaginal birth after C-section. When you have C-section, right, any sort of interventions, those actually increase the risk of complications and of harm.
Are we the only people, Black Americans, are we the only people who have had this experience of having our pain not be treated appropriately?
It's interesting. I have some colleagues in the UK that actually, even though the UK has universal health care, they have socialized medicine, there still are these disparities around race where Black patients and patients of color are not getting the same care. And I think that probably is related to colonialism and othering of people. And also there's that mistrust also, where even though they have access to care, they don't feel like if they go to seek care, they're going to be listened to.
Was there ever a disparity between, for example, white men and white women?
So there is. So we see in the United States, there are gender disparities in terms of how a lot of clinical issues are treated. Because initially, most of the studies, for example, on heart attacks were done in men, in white men. So there's like this, initially you're taught about these classic symptoms, right, of what a heart attack feels like. But for women, that's very different. And so often what we see is when women are complaining of these symptoms, there are misdiagnoses because people are saying, you don't have the classic symptoms, so you can't be having a heart attack. Right? And then there's also this idea, a lot of gaslighting that happens with women when they seek care. So this idea of like, no, you're just like, that you're not really feeling that. That's just in your head.
That still happens?
Yeah, it still happens. But what's also interesting is that like there are studies that show that women physicians, like we're more likely to listen to patients. Patients have a higher degree of satisfaction with us. We actually have like lower like miss rates. We have lower readmission rates. And I think a lot of it is just because like we're used to sort of kind of sometimes being on the periphery. We're used to like not being listened to. And so we want to make sure that our patients don't feel that way.
So, okay, so if you're not someone in one of these groups and you're going, whenever I think about our show, I think about the fact that like I probably have my own biases, right?
Yeah,
like my own ways of thinking about things. But I think about people who are skeptical, who would be sitting here listening to us and going, how do they really know? How do we actually know that this is true and it's not just one-off things?
Right. And actually, I think I may mention in the book that when we compare Black immigrants, the health of Black immigrants to Black Americans, we see that when they first come to the U.S., their health is actually on par of that of white Americans. But like 2 generations in, their health status worsens to that of Black Americans.
Oh my God.
So, so there is something about living in this country that it's actually unhealthy for everybody because when you look at life expectancy and maternal mortality
for
every racial demographic group, we are just doing very poorly compared to our other peer high income nations. But when you look for people of color, it's even worse. And so, like, the example I'll give is even myself with a Harvard undergrad degree, Harvard Medical School degree, my risk of dying of maternal complications, there's data, is higher than a white woman with an 8th grade education. So socioeconomic status, professional level of attainment is not as protective for women of color as it is for white women. So people would say, well, why is that? You have access to
like some of the probably the best healthcare,
the best doctors. And so what we know is that access to healthcare is only one piece of it, but we also know what we've talked about before, that when we go interact with clinicians, they may not be listening to us. So that's one piece, right? But the other piece is something they talk about in the book called weathering. There is a public health researcher named Dr. Arlene Geronimus at University of Michigan who's been doing this wonderful research for the last 30 years that shows that even just like the stress of living with everyday racism for women of color, like it actually has an impact on your body. We internalize stress. And what that does is it causes one of our hormones called cortisol, our stress hormone, to increase. So the body is used to it increasing every now and then. But when you are like internalizing what's happening to you on a daily basis, that stress hormone, it just is up high all of the time. What that does, it has impacts on your blood sugar. It has impacts on your heart, on your blood pressure. And that impacts like your predisposition to developing a lot of chronic diseases that we know are more prevalent in certain communities than others.
Well, and I mean, if we even widen this, it feels like recently that people are starting to more widely accept that emotional experiences impact our physical health.
Absolutely.
It's crazy when you really think about the fact that we didn't believe that, and some people still don't. But like when I listened to you talk about this, I thought of, my grandfather passed away 9 years ago. He had diabetes. My grandmother is 95. She has high blood pressure. My mom has like slightly high blood pressure. I felt like growing up, when I first heard Grandpa had diabetes, it was just like, this is just a thing.
Yes.
And Black people in Black communities are more susceptible to this. And that was kind of where the conversation stopped.
Yeah.
So as I've learned more, I'm like, oh, why aren't we having these conversations about the things that are impacting our physical health, no matter what age, right?
Right.
We're not having those conversations as much.
Oh my God. Everything that you said is so important. And I feel like, again, even myself as a physician, these are things that I did not learn about. Like I had to supplement my my reading.
Right, correct. We have to go to school by ourselves.
Yes, to learn all this. And so that's why the work that I do in terms of health equity advocacy is so important, because I really want the public to understand. But one thing that you mentioned that I also wanted to just get into a little bit more is there is the weathering piece, but the other piece is this idea of generational passing on of not only trauma, but chronic diseases. There's a lot of really wonderful research called epigenetics, that stress, and this is not just about race or racism, but that stress turns on and off genes, right? And so you can have a gene that predisposes someone to diabetes because of the stress that they're going through that turns on a gene that is responsible for blood sugar control.
Right. So then when you're diagnosed with diabetes, I mean, epigenetics feels newer to me too, as far as just hitting the general public.
Right.
But 20 years ago, if you're diagnosed with diabetes, no one's going, oh, the gene got turned on.
Right.
How'd that happen?
Exactly.
Yeah,
exactly. And I think again, thinking about how I was taught, that race is a risk factor for certain diseases. So again, there's that teaching of there's something biological about race that's causing you to be predisposed to these diseases, where no, it's really what's happening in the environment.
Coming up, how do we reckon with the past and work towards a more equitable future? Dr. Blackstock and Leah will get into that, plus tips on how to advocate for yourself as a patient for the next time you see your doctor. We'll be back in just a few moments. And we're back with Dr. Uché Blackstock.
I've been thinking about this, you talk about this doctor, J. Marion Sims, who was literally revered for his work when it comes to gynecology and women's health.
He's considered the father of modern gynecology.
And you and I live this is New York City. This is a pretty progressive place. Right. And he had a statue in Central Park that was erected for him and was up until, 2018 or 2019?
2019, yeah.
Okay, so talk to me about his story and how do we reconcile that?
Yeah, so he was the grandfather of modern gynecology. He actually was the first president of the American Medical Association, which is the oldest and largest organization of physicians. He essentially was someone, like you said, was incredibly well respected and revered, but he performed these very painful surgeries on enslaved women without, obviously they couldn't give consent. And even once local anesthetics had been developed, he didn't use it on them. And so, there was a statue of him across from the New York Academy of Medicine for a very long time. His picture is in numerous medical centers. But it really wasn't until 2019, 2020 that there was more of a reckoning with what he did. And so I think when you hold these two truths that yes, he made these very important discoveries, but also he did so in a horrific, immoral, unjust way. For someone to be both a physician and an enslaver, to me, that is almost incredibly contradictory. There's a huge amount of dissonance for me with that. I think what's important, not only do you take down statues, but you also have to have conversations within the medical community about why this person should not necessarily be revered.
Right.
That you have to recognize the harm that was caused and then talk about how are we going to reconcile what happened.
There's something I think really important about just recognizing how easy it is to live with that dissonance when you've justified in your mind that, well, this person blank, 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 which I think actually happens a lot today. So, even if it's not just Black maternal health, how many times do we in our mind justify the treatment of someone else that we know we wouldn't accept for our family or for people we love. But because this person's this way, we're able to do this. And obviously done with slavery because, for much of the time we were considered to not be human. Fully human, right? So that makes life really easy when you're we'll just operate on these people. Can you talk about that? And I'm curious if you've seen it elsewhere. What What do you make of that?
It's challenging because I feel like it's like, how do you instill empathy in people?
Yeah, it's tough.
I think definitely from like a physician perspective, I know that there are things that we can do in medical school and in training, to make sure like we're talking about this stuff, that it's part of the formal curriculum, that we are like really reckoning with it. And so actually after 2020, a lot of students were like, we're writing demand letters to their administration saying, listen, we want to make sure that these topics are included in our curriculum, because they weren't when I was in medical school. When I graduated in almost 20 years ago, I didn't learn any of this. Medicine and healthcare, even though we'd like to think of ourselves as very innovative, we are like...
It's an old system.
it is such an old system.
Yeah.
And so it's going to take a while to get out of that traditional way of doing things.
Right.
But I also always bring it down to, look, these are the statistics we have. We're not doing well.
We're not doing it. Yeah, we're not doing great.
No. And our patients deserve better. Like, I think about it as like missed birthdays, missed graduation parties, missed retirement parties. That's how I think about how like racial health inequities in our country impact people.
So you said it's 6% of doctors in the U.S. are Black doctors, less than 6. What do you need people in the medical field to know?
I need for them to know, and this sounds really simple, but first of all, just to listen to your patient. You are an expert in a certain body of knowledge, but your patient is the expert in their body. And that we need for you to have some humility in these interactions with patients. Because we know that often doesn't happen. There is this power dynamic.
Right.
Often patients don't feel comfortable speaking up. They don't feel comfortable asking questions. And so we need them to be able to create a space for their patients to feel like I can share what I want to with you. And I know that you're going to listen. I know that you're going to take me seriously. I feel like that explicitly needs to be said.
How simple is that?
I know. And then I think the other piece is that we do need, unfortunately, because of how all of the isms are so embedded in our systems, we do need to have like standardized processes and protocols. How are hospitals going to hold themselves accountable? But this is the kind of things that we need to teach our students too. Like, yes, there is the work that needs to be done on an individual level in terms of self-reflection, on an interpersonal level, the way that you interact with your patients. But our doctors to be and our current physicians and health professionals need to understand what is the way our systems work that actually can reinforce the harm we may be causing to them.
It feels like sometimes rethinking the system, rethinking a lot of these systems is like trying to re-steer the Titanic. So it's like, will the system ever change as fast as the individual can, has been my question. And my assumption, and whether right or wrong, was like, no. And so I want to use, this show and the work I'm doing to show people how to impact their own change and to become more self-aware, because I think both things have to happen.
Oh, absolutely.
But one may not happen as fast as the other. And if individuals aren't aware, then to your point, it's like, are there things that we could do that would keep us from missing birthdays or graduations? And so I'm curious what you would say to people who are patients.
Yeah.
What do they have to know?
I know. And I struggle with this question because I feel like it's putting like...
I know.
It's putting the onus in the... No.
Yeah, I know what you're going to say.
No, the burden on the patient when it's a systems issue. But of course, like, I would love for anyone that, interfaces with the healthcare system to understand, like, to have some, at least just baseline knowledge of health and health literacy. And that's something that actually in this country we can do better on, because there is so much misinformation out there. And there's a lack of trust of institutions for all groups, And so we really need to think about where people are getting their information from, and do they understand it? Like, so most health information should really be conveyed at a 4th to 5th grade education level.
It's not.
Yeah. And I have to tell you, like, even when I started doing a lot of my health communications work, I was like, wait a minute, we're expecting everyday folks to understand this information, and we're coming out with like new studies every day. Like
how do you know what study's right? How do you know which one?
Exactly. So I think there's a part that we have to work on, health systems, agencies, health agencies, in terms of how we convey information to people, and making sure that there is health literacy and that they know where to find accurate and responsible information. But I also tell people, everyone's a patient, including me, that you should always bring someone with you to an appointment. If you can. Either a loved one, a friend, because often when you're not feeling well, which is why you're going to the doctor, you are not able to think clearly, you may not be able to ask the right questions. At least they can be there for moral support or to like actually ask questions in your behalf. So I think that's really important. I think also, honestly, I don't have a problem with people doing research before they come to the doctor on their symptoms. Like people say, I hate,
that makes me feel
Dr.
better.
Google.
I'm that person.
Listen, I'm that person. I'm still that person. I'm an emergency medicine physician. I don't know everything about every specialty, so I may look things up as well. But just making sure that you know that you're looking at the at an accurate, responsible resource. I think that is incredibly important. I think that also knowing to ask your clinician, like, what do you think is going on with me? Like, really clearly, what do you think is going on with me? What are red flags I should look out for? What are reasons I should come back for? What is your plan for me? Like having those questions written out, but then also writing down like, what are the symptoms you've been having? Like, how long have they been going on? What helps? What makes things worse? Like, because a lot of times when you get in front of a doctor, you're just sometimes not able to think clearly. Make sure you write all of that down. And then ultimately, I feel like if you see someone and they're not really listening to you, don't hesitate to get a second opinion. Even if you're in the emergency department, you can say, look, I'm not feeling good about this interaction right now. I don't feel like you're listening to me. I'd like to see another provider.
I just want to pause and say we can say that as patients.
Oh, absolutely.
Like with the, I think with the like power dynamic for any of us, we assume I walk into a hospital and everybody knows better than I.
No, absolutely. And then also a lot of hospitals have a patient advocate. So you can also call for the patient advocate and talk to them, and they'll help to facilitate difficult conversations sometimes.
This is obviously not a conversation that's meant to like instill fear. It's actually about like education and being empowered to, Yeah,
and actually I'm very thoughtful about that. Like I don't want people to get scared per se. I definitely want them to be vigilant. I want them to be able to advocate for themselves. At the same time, like, obviously we know the statistics, right? So the ideal is that, every patient should go in fully informed, right? With everything they need to advocate for themselves.
Yeah. Talk to me about your mom, because she passed away at 47. When you think about your mom, what legacy has she left for you? I've heard you talk about you and your sister going, like, we want to be just like mom. Like, what legacy has she left for you, and what legacy are you hoping to leave?
It's interesting because I just turned 47 last month, and the year that my mother was when she passed away. And, looking back, when I was 19 and when she passed, she was just my mom. And now I'm 47 with all the multiple roles that I have. I'm also a mother and a physician. And I think, now I can appreciate sort of the complexity of who she was. And I admire her even more now. I'm like, how was she able to do all of that? And I think for me, what the legacy piece is really amplifying the work that she was doing on a community level in our neighborhood. Like she was doing all of this really wonderful health equity work in the 80s and 90s with other Black physicians, holding community health fairs, making sure patients had follow-up services. And so I feel like the work that I do now is sort of a continuation of that work that she started then. And so really I just want to commemorate her legacy, commemorate the work that she has done, and for people to know about her.
I love that. And happy birthday, by the way.
Thank you.
So what do we need to know for those people who may, end up wanting to grab your book but not get to read it? What do you believe that people need to know from Legacy, given this is for, you said, a broad audience? Yes,
I think that what people should know is, how did we get to where we are, where you and I are having this conversation about these statistics, that there are historical reasons rooted not only in slavery and Jim Crow, but even in how patients today often are not heard or listened to by clinicians. There is a reason for all of this, and we should be outraged. And I end the book with a call to action to different groups, and one call to action is like thinking about, even if you're not in medicine, like what is a difference that you can make in your life with people around you, and amplifying community-based organizations that are doing actually so much of the work to address these racial health inequities. I talk about a birthing center in Minneapolis, Minnesota, founded by a Black midwife with the express mission of providing respectful and dignified care. And they've been able to show that they've had, through data, improved maternal outcomes.
Wow.
So, I think you don't always have to be like, oh, it's so overwhelming. Yes, it's so overwhelming. But there are things happening on a hyper-local and local level. There is something that each of us can do in our respective roles, whether it's individual, interpersonal, systems level, in thinking about how do we address these racial health inequities? How do we make sure that in a country with the resources that we have, that everyone has the best health, right? So that everyone can live and go to these birthday parties and graduation and have retirement parties that they deserve.
Thank you so much for being here. This has been amazing. Me. Yes. I'm going to have you complete these 3 statements for me before you go.
Okay. Hopefully
no pressure. No pressure. Better humans are
people who want to do better.
Better work is
being able to show up as your full self.
What does that mean to you?
Oh, it means just being able to share your experiences, being able to speak up about things that you see that don't seem to be working, feeling comfortable in your skin.
And a better world has?
A better world has opportunities where everyone can live long, full, beautiful lives.
Oh, I love that. Thank you so much, Dr. Blackstock. This was amazing.
Thank you for having me.
That was Dr. Uché Blackstock, author of Legacy, A Black Physician Reckons with Racism in Medicine. Everyday Better is a production of LinkedIn News. The show is hosted by Leah Smart and produced by me, Grace Rubin.
And me, Emily Reeves.
Asaf Gadron is our sound engineer. Tim Boland mixed our show. Andres Cardona is our video producer. We get additional support from Alex Kuznetsova and Ali McPherson. Sarah Storm is our senior producer. Enrique Montalvo is our executive producer. Dave Pond is head of production and creative operations. Maya Pope-Chappelle is director of content and audience development. Courtney Koop is head of original programming. And Dan Roth is the editor-in-chief of LinkedIn. Thanks for coming with us, and we'll see you next week.